Great. So we'll start. So as usual, there'll be one question and we'll be having the discussion from that on. Okay. So we'll start with a discussion and a question and a poll. See the question, look at the image, and try to write the correct answer. Fine. I'll end the poll. 30 seconds, I think, should be good enough. Okay. Okay, so this is definitely a lymphoma. You have the image and you have the CD markers, everything lined up for you guys. So first, we'll look at the image soon. I want to look at the CD markers and decipher if you can rule out few things based on the CD markers. CD5 negative. Can you rule out anything based on CD5 negativity in this list? Burkitt's, DLBCL, follicular lymphoma high grade, and your lymphoplasmatic lymphoma. Possible? Not possible, right? I cannot rule out anything. CD5 negative positive lymphomas will be two things, mantle and CLL. Both of them are not here, so I'll not be able to rule out anything based on that. So it's a useless information given to me. I have an atypical lymphoid population depicted in this photomicrograph. Yes, definitely, it's definitely pleomorphic. You can see few cells with one or more than two nucleoli as well, right? Definitely a pleomorphic one. Can this be Burkitt's? 60-year-old person, Burkitt's? Unlikely to be Burkitt's, and you don't have the classical starry sky appearance of Burkitt's, so I'm going to rule out Burkitt's. Follicular lymphoma high grade. What do you think of follicular lymphoma high grade? A high grade follicular lymphoma is almost equivalent to your DLBCL, right? The grade 3 follicular lymphoma is nothing but a DLBCL transformation, fine. It's a DLBCL only, so I am going to ignore this. Should have not been in the option, but fine. Lymphoplasmatic lymphoma. What's the other name of this? IgM secreting lymphoplasmatic lymphoma. We have your Waldenstrom's, right? So should I have had few markers suggestive of plasma cell neoplasm if it is lymphoplasmatic lymphoma? Yes, like Shastri said that I should have your CD 38 and CD 138, right? I don't have anything of that, so I'm going to rule out that as well, right? I'll go with DLBCL. Okay, why not follicular lymphoma high grade is to say in follicular lymphoma high grade, what is the pathogenesis, primary pathogenesis in a follicular lymphoma? What mutation or what translocation happens? BCL2, right? I don't have something of BCL2 here. Unless I have BCL2, I cannot say that this DLBCL has stemmed from follicular lymphoma. If I have that, yes, at least some evidence is there. Here, since that evidence is not there, I'm going to go for DLBCL. Okay, clear? Just have a few things about lymphoma on the photomicrographs. See, I'm sure that you guys know how to differentiate lymphoma based on your WHO classification: B cell, T cell, pre-germinal center, germinal center, and post-germinal center neoplasm. But unfortunately, that will not help me for microscopic diagnosis. For a microscopy, we're going to divide them into just 3 rules. Your small cell lymphoma, which we already know, your intermediate lymphoma, and a large cell lymphoma. This is an easier way to diagnose for me on a micrograph. So when I see an histology, based on this, I will be applying markers, and you guys know the markers. Based on that, I'm going to come to a perfect diagnosis. When I say small cell lymphoma, what are the small cell lymphomas which comes to your mind? There are only 4 small cell lymphomas for me. CLL, mantle, just perfect. I have follicular, and I'll have maltomas or your marginal zone lymphomas, right? These are the 4 small lymphoid neoplasms I'm going to have. Intermediate is only one. I'm just going to ignore intermediate. Intermediate is equal to Burkitt's. Burkitt's is equal to your starry sky. So at least for undergraduate, I won't disturb anything beyond starry sky and Burkitt's. That will be diagnostic. Large cell lymphoma, since we are discussing B cell neoplasms, DLBCL. ALCL, anaplastic large cell lymphoma also will come there, but it's a T cell neoplasm. We'll stick on to B cell, right? So next question comes, how do I differentiate a small cell and a large cell? I need some evidence, right? I have to compare to some person. 2 things we can compare to. In any lymph node, am I right in saying that we have macrophages? Yes, and also blood vessels. These are 2 things. You have to either compare it to macrophages, if possible, the nuclei of the macrophages, not the entire macrophage. Can a macrophage be this big also? If it's going to eat too much, yes, it's going to be like us. It keeps on eating. So don't compare the entire size of the macrophage, the nucleus of the macrophage, because sometimes you go to the size of the macrophage, you can't. It can be of enormous size, so it might be confusing. So nucleus of a macrophage, I'm going to compare. If you are not seeing any macrophage, go with blood vessel. In the blood vessel, endothelium of the blood vessel. Fine. So if it is something smaller than that, it will fit into by small cell lymphoma. Equal to it is going to be my intermediate. The cell is larger than that, I'm going to have a DLBCL, right? You're just going to compare with the nucleus of the macrophage or your blood vessel. Okay, I'll show you two images. I'm not going to give you buckets. You're going to tell me whether it's small cell or large cell or intermediate, right? I don't want anything else. I don't want diagnosis. Let's see this, if you understood or not. The one which is circled in yellow is your macrophage. It's definitely a small cell lymphoma, right? My nucleus of the macrophage is this big. So the lymphocyte which is adjacent to that is definitely small. My small cell lymphomas. See, first preliminary diagnosis based on this. I'm going to take get a biopsy of lymph node. Once I look into the microscopy, I'm going to say, okay, it's a small cell lymphoma. If small cell lymphoma, you have the 4 differential diagnoses. Then I'm going to apply IHC. What will be the first IHC panel you will apply? I have seen it's a small cell lymphoma. What will be the first panel you'll apply? First is B cell, perfect. Before CD5, I want to apply B cell. If it is a T cell lymphoma, then everything will be wasted, right? So I have to apply a B cell marker first. So the first thing is obviously my 19 and 20. Let's assume for this case, this is positive. So I'm sure it's an B cell small lymphoid neoplasms. I have only 4 B cell small lymphoid neoplasms like told. So the one thing which can primarily help me to differentiate them is CD5. When I do CD5, CD5 is a T cell marker or a B cell marker? Normally, a T cell marker. CD1 to 8 are T cell markers, right? There are 2 B cell neoplasms where CD5 will be aberrantly expressed. A B cell neoplasm which is formed before germinal center entry. What are the B cell neoplasms which are pre-germinal center? Mantle and CLL. Those alone will express. Once they go into the germinal center, it's not going to express CD5. It will be gone, right? So if CD5 positive, I have 2 possibilities. CD5 negative, you have 2 more possibilities. The follicular and your marginal, right? So I'm going to differentiate between CLL and mantle. That's our goal. We'll not go into CLL because that might be sometimes confusing for you if you don't know the base things. Mantle, what is the mutation seen in mantle? Mantle, what's the translocation seen in mantle? 1114, which is involving cyclin D1, right? So I'm just going to go to cyclin D1. Cyclin D1 positive, mantle, which means cyclin D1 negative, CLL. The other marker, like some of you guys said, CD23. CD23 positive, CLL. CD23 negative, mantle, right? If you know the B cells journey, it might be much easier. And as of now, I'm going to go with this flowchart. If it is negative for CD5, again, I have 2 possibilities. Your follicular and marginal. I just write FL follicular lymphoma and your marginal zone lymphoma. Of these 2, which is germinal center origin? Follicular lymphoma is germinal center origin. Tell me the markers of germinal center. 10 and BCL6, right? Ideally, 10 is a predominant one for me. 10, and obviously a little bit about BCL6 as well. If it's positive, and obviously I need one more thing. The mutation, like you guys said first, I'll have BCL2 translocation, right? If it is positive, I'm going to call it mantle. Sorry, follicular. I need BCL2. Without BCL2, I cannot call it. 10 and 6 is just for the origin. It's coming from germinal center. BCL2 tells about the pathogenesis. Margin zone lymphoma is germinal center or post-germinal center? Post-germinal center, right? So when I say post-germinal center, I will not have these markers. CD10 will be negative. BCL6 will be negative, right? I just need one more marker for B cell, 79A or 79B. Whatever it is, that should be enough. I have one more marker called CD43. I can use this also. That should be enough to say it's marginal zone lymphoma. Maltomas and marginal zone lymphomas, most of the time, diagnosis of exclusion. If nothing fits in, try to put one more B cell marker for maltomas. This is for my small lymphoid neoplasms. So if you see a small cell here in the image, these are the only possibilities if they are B cells. We're not talking about T cell neoplasms today, only B cell neoplasms, right? If it is intermediate, we have only one person, Burkitt's, and we're not going to be much bothered about Burkitt's. It's a straightforward diagnosis. Only one marker is required for me. CMYC positive, I'm going to call it Burkitt's, and Starry Sky is for Burkitt's, right? Yeah, 43, positive. Okay, fine. So this neoplasm, small, large, or intermediate. Let's say that this is my endothelial cell. Sorry, this is my endothelial cell. You can see the RBCs here, right? My endothelial cell, small, larger, intermediate. Undoubtedly large, right? As such a huge B cell neoplasms, undoubtedly large. So if it is CD20 positive, I have only one differential diagnosis here, DLBCL. High grade neoplasm or low grade neoplasm? Yeah, there's no macrophage here, but you have the blood vessels, right? You can see the blood vessels here. You can see RBCs, you can see the blood vessels here. Fine. So with blood vessel endothelium or macrophage, I'm going to compare. Fine. DLBCL is definitely high grade. If you have any high grade disease, leave lymphomas, any high grade disease like COVID, do you need prognostic factors? For any high grade disease, I might lose a patient. So I have to have a perfect distinction saying that, okay, this is going to be better prognosis somewhat. This is worst prognosis. I'll definitely lose the patient. I'm just softening the blow for the patient. That's all. I need to categorize them: good prognostic factors, poor prognostic factors for almost every disease where you're going to lose the patient. So the way to diagnose DLBCL is, tell me if DLBCL, what is the origin of DLBCL? Germinal or post-germinal? So we have difference of opinion. So can it be both? Yeah, I can have both germinal center and post-germinal center neoplasms, right? So once I have a diagnosis of DLBCL, if before I'm going to give it to a hematologist for treatment of DLBCL, a hematologist obviously will ask series of investigation. One, I can do it on a IHC itself. For others, I require a fish, right? So first diagnosis is distinction between an germinal center B cell neoplasm and an activated B cell called as ABC type. Without this distinction, no hematologist is going to touch the patient. They need distinction. They need fish also. They need molecular genetics as well. They're not going to give treatment before, if everything is available. If the person is affordable and they are able to do, this is how the protocol says. I'm going to do everything. So to differentiate germinal center B cell versus and post-germinal center, I have this algorithm. This is called as Hans algorithm. Okay. If CD10 is positive, this percentage is more than required. More than 30% of the DLBCL cells should be CD10 positive. Then yeah, I'm going to directly sell as a germinal center B cell type, right? If it is negative, I'm going to apply the second germinal center marker, BCL6. If that is also negative, I'm going to say it's a non-germinal center neoplasm, activated B cell type. Non-germinal center is also called as an ABC, activated B cell, which is post-germinal center cell. If BCL6 is positive, again I have possibility MUM1. MUM1 is what marker? Germinal center marker or post-germinal center marker? It's in post-germinal center marker, right? So your post-germinal center marker. After this, I can have, if it is positive, I'm going to go for a non-GCB or your ABC. If it is negative, I'm going to go for GCB again. So I have to report on this. I have to report on this, and only then, sometimes even this is not enough. I'll report like DLBCL, let's say an ABC subtype, right? It'll have a worse prognosis. Post-germinal center subtype will definitely have worse prognosis compared to a pre-germinal center subtype, right? Sometimes what happens is, can these lymphomas, it's a DLBCL, like someone asked, Moki asked, right? How can I rule out a follicular lymphoma high grade? Can these lymphomas have BCL2 mutation? Yes, I can have. So tell me, I have a de novo DLBCL. I had a follicular lymphoma. It progressed to DLBCL. So it's already progressed. Will they have a bad prognosis? They'll have even more bad prognosis, right? Can a Burkitt become DLBCL? Yes. Can a CLL become DLBCL? Yes. So all these are high-grade neoplasms. All the neoplasm, all B-cell neoplasm can become DLBCL. So what we did was, anything can become DLBCL. So what we did was, I need to know whether BCL2 is involved or not. I need to know whether CMYC is involved or not. So we had different things. Let's say a DLBCL with a BCL2. I call it double hit mutation, double hit lymphomas. With BCL2, BCL6 or CMYC, I call it triple hit lymphomas, right? So this also is required, especially when the person is not performing well. We have this, I'll zoom a little bit. They have something called as double hit lymphomas, which means it's a high grade lymphoma with rearrangement of MYC and BCL2 or MYC and BCL6. It's MYC, BCL2 or MYC plus BCL6. Ideally, I should do it on a fish. It should be done on a fish. I'll show you fish image as well, how to pick up them. If it is triplet lymphoma, this is triplet lymphoma. I need rearrangement of CMYC, BCL2 as well as BCL6, all three. Triplet lymphomas undoubtedly is going to have the worst prognosis of all. Let's assume if a person is not able to afford for fish is going to be expensive. So I need an alternative, right? I do an IHC. Just tell me one thing. If IHC is expressing, if IHC is not expressing, both of them can have a mutation, right? I can have a mutation with expression as well as no expression. Possible? Yes, possible. I'll answer your question, Mithun. It's possible, right? So I'm going to use a different term for it. If I'm not able to afford for a fish, which is genetic analysis, I'm just looking at the expression. I'm not looking at the mutation, right? I call them double expressor. If I have c-MYC plus BCL2 or BCL6, I'm going to call it a double expressor lymphomas. Again, the cutoff is going to be more than or equal to 30%. The positivity more than 30%, I call it double expressor lymphomas, right? This also is required for the hematologist to go ahead and plan the treatment. Doublet, triplet lymphomas, straight away they go for an aggressive approach. Dilip will be talking about that, right? They go for an aggressive approach, right? See, combinations other than this are a bit rare. It might come. I'm not saying it will not come, right? It might come. It's not like it will not come. If it comes, I'm going to look on the patient basis. There are few provisional categories we can put into it and go ahead with the treatment, right? See, maltoma is an low-grade lymphoma, right? Just maltoma. This everything for a high-grade lymphoma for a DLBCL. Okay. No, Varun, when I say expressor, when I'm going to say expressor, I'm having more and more mutation. Let's assume I'm having a DLBCL. Onto the DLBCL, I'm having a c-MYC mutation. Do you think that DLBCL will grow faster? What will MYC do? MYC is like a proto-oncogene, right? It will grow faster. So when it expresses more Warburg grows faster. So more and more mutation accumulate, it's going to grow faster. So it becomes a terminal stage 4 easily, and you're going to have a trouble. Fine, great. So now let's understand how to do an doublet and triplet if a fish is given. I've taught you already about how to identify fish BCR-ABL, right? How did you look at fish BCR-ABL? We know that already. We had a nucleus like this, let's assume. So we had two colors, green and red. Let's assume that this is BCR and let's say this is ABL. I'm using the color combination very weirdly. Okay, BCR and ABL. So normally I will have BCR here, ABL here. So what we thought is when I had a translocation of 922, what should happen to the colors? They should come closer, right? Either they should come closer and completely become yellow or something of this sort, very closer, right? This is what we saw. This is called as a fusion fish. I cannot use a fusion fish here. These are fusion probes. I cannot use it here. For the only reason, let's assume c-MYC translocation in Burkitt's lymphoma. Am I right in saying that c-MYC can get translocated with 14, 2 or 22? 814, 28, 822, right? I have different permutation combinations here. So I have to do 3 fish. One for 814, one for 28, one for 822. Otherwise, I have to do different colors. I don't have so many fluorochromes. Even if I have it, it's going to become very expensive. So what I'm going to do is, this is a chromosome, right? This is a normal chromosome. Can I stain here and here for a single chromosome with 2 colors? Let's assume this is your chromosome 8. Chromosome 8 is where we see MYC. I've stained 5' by one end, 3' by other end. If there's a translocation, either this part will break or this part will break, right? If this undergoes translocation, in a normal fish, if I'm going to stain like this, listen carefully. If you don't understand, let me know. If a normal fish, I'm going to stain the 2 parts. One is going to be here, the other one is going to be here. If there's a translocation, am I right in saying that these 2 signals will become wider apart? This is normal. If there's a translocation, these 2 guys are going to become wider apart. It's going to become here and here. I don't care if it goes to 14 or 2 or 22. By staining a single thing, I will know that it's translocated. That's enough for me for a doublet or a triplet lymphoma. This fish, we are going to call it as a break apart fish. It's breaking apart, right? These are break apart probes and break apart fish. Okay. So I'll show you images. Let's see if you can get it, understand whatever I said. Look here. It's written, maybe I'll zoom a little bit. It's written 5' is c-MYC and 3' green was 3' of c-MYC. So I'm having an image like this. This is normal or abnormal? Whatever I circle. 5', 3', very close together. No, this is normal, right? This is not fusion fish. This is normal, fine. So other chromosome, I'm having 3' in one end, 5 prime in other end. Is this possible without breaking? This one is not possible without breaking, right? So this is an abnormality. Okay. So since I am using both for CMYC, it has to be close together only because they are the same chromosome. It has to be close together. If it is broken and separated, this is how break apart probes work. Fine. Look at this again. BCL2 and my 5 prime and 3 prime of BCL2. Is this normal? Just to understand again, is this normal or abnormal? Whatever I have circled. This is normal. These two, it's broken apart and it's gone back, right? That's abnormal. Fine. This is how a break apart fish will look. I'm going to use break apart fish when I don't know what is the other participating chromosome. Because one chromosome I know, BCL2 I know. I don't know what is the other participating chromosome. It can go with translocation with any one of the 26 things we have, right? It can go anywhere. So I'm going to use break apart probes. I'll show you images just to see if you can identify. See, I'm going to use BCL2 in the first panel. If you want a little bit zoom, tell me, just concentrate on this cell alone. Tell me it's normal or abnormal. Is there break apart or not? Yes, it is abnormal. So this guy should have been normal. These two are definitely broken apart, abnormal. This guy is normal, this guy is abnormal. So can I say here BCL2 is abnormal? In this person, BCL2 is abnormal. Let's look at CMYC. Same here. Normal, abnormal, right? So here again have normal, abnormal. This is also abnormal. So I have double hit and triple hit lymphomas are done by fish. So once I get this, I'll give a report. The entire report should have everything. It should be a DLBCL. There are some microscopic subtypes also. That also should be there if possible. ABC subtype. And as in double expressor or double hit lymphomas. This will be done by the cytogenetics fish. So once it is done, it will be going to Dr. Dilip and Dilip will be taking over from here. I'll mute myself so that you can hear him clearly. Over to you, Dilip.
Thanks, Ranjith. I think we had to look at DLBCL from a different perspective because previously for any non-Hodgkin lymphoma, it was straightforward R-CHOP regime. So that's what the treatment part. No, I mean, in exams till now, the treatment of any non-Hodgkin lymphoma, if you ask about, they're going to ask about this R-CHOP regime only. But right now, things are evolving and we are giving a lot of newer forms of chemotherapy. And as we understand the disease more and more, as Ranjith said about the double hit and triple hit therapy types of lymphoma, as we're moving further and further, we believe that there are certain special types of lymphoma which have a bad prognosis and they need a different sort of treatment that we're going to see at the end. So this is the same exact slide that I used to show to my DNB residents also. As far as DLBCL is concerned, each and every lymphoma I have a different slide, but this is the one slide I generally tend to show to all of my DNB residents. First, DLBCL wise, it is the most common type of non-Hodgkin lymphoma. Everyone knows that, and the peak incidence of DLBCL is going to be around the 6th decade. So it is the disease of the elderly, if you really want to ask about. And as we discussed, I think Ranjith said rightly, large cells. Like you're going to see the large cells with loss of follicular architecture of the node. So whenever a biopsy report comes, I mean, the pathologist will see a lot of things, but what as a physician I'm going to look for, or what as a hematologist someone is going to look for in the biopsy report, in the histopathology, I'm going to look for the paracortical area of the lymph node. Then I'll be looking on the lymph node sinuses, whether is there any granulomas or not, and is there any loss of architecture. Then I'll be looking on the type of the cells. So this is what I'm going to look for. I think Ranjith will agree with that. I mean, these are the 5 things that I generally see whenever I get a biopsy report of the lymph node, because we commonly send the cervical lymph node biopsy, which is so common. So we do get tuberculosis, very common, but there could be some cases which can come with lymphomas, and it can be like Kikuchi-Fujimoto disease. So there are some various possibilities are there in a young patient or elderly patient who come with a lymphadenitis, or we take a lymph node specimen. So what I'm going to look for, 5 things. The first one, of course, is going to be the paracortical area. So whether it's just a paracortical expansion or not. So that's what I'm going to see. Second, I'm going to look at the sinuses. Third, I'm going to look at the presence or absence of granulomas. Fourth, of course, I'm going to look at the architecture, whether it is lost or not lost. And fifth, of course, I'm going to then look at the type of the cell. So what are the cells that are mentioned by the pathologist? So I think, Ranjith, you want to add something else in this?
This should be more than enough. Like only one thing, sinus, when I'm going to look for sinuses, when I'm going to think of a metastasis, because sinus is like mets will first involve the sinus, and there are few things which I think you guys know, that the sinus histiocytosis. Those will involve the sinus predominantly. And yeah, granulomas is undoubtedly for every lymph node, the first thing is such a granuloma. Paracortical area expansion has a few connotation, few significance. And apart from this, like what you said, kikuchis are rare things. But yeah, it is, once we evaluate more and more, we are getting more and more kikuchi. Initially, it is said that kikuchi is a very, very rare disease. We at least see once a month, 1 or 2 kikuchis. It's become so common. Once a month, 1 or 2 in a peripheral center is definitely common, right? So more and more we evaluate, we are getting more and more new diseases, which when I say it's kikuchi, it has 2 things. One, it can go back to itself on its own. Second, I have to look for SLE in the patient, right? So those are very important. See, granuloma, it is not for cancer especially. It's just what are these things I'm going to look for in a lymph node, that's all. Tuberculosis, granuloma is equal to tuberculosis. Yeah, Kikuchi Fujimoto disease. We'll see it once some other class. Okay, fine. Go to Dilip.
Yeah. So as Sanjit said, Kikuchi Fujimoto, once the diagnosis made, the patient has a high risk of developing systemic lupus erythematosus in the future. So generally, we tend to do ANA every 3 to 5 years, especially if it's a younger individual without any symptoms, then we'll do once in 3 to 5 years. Maybe later on, if the patient is having some high-risk features, then probably you need to repeat ANA every year as well. So the patient has some high-risk features. So otherwise, 3 to 5 years ANA is more than enough. If the patient is having a Kikuchi Fujimoto disease, that's fine. So, I mean, what I was trying to say is these are the 5 things I'm going to look for as a physician. So pathologists generally look extensively for a lot of things within the lymph node in the biopsy. But as a physician, in the report, I'm going to see these 5 important points. And DLBCL can present as extranodal disease also in the stomach, central nervous system, testes, or the skin. So it can present as an extranodal disease. But as such, the GI involvement is quite common. And of course, it's curable in 60 to 70% of the cases, in the sense you need to make a diagnosis faster. So before it gets disseminated, if you diagnose much beforehand, so it is curable in almost 60 to 70% of the cases. And median survival is going to be in the order of weeks to months if it's not treated. So that's why early diagnosis and treatment is very important. And there are some risk factors of CNS involvement, so which I want to substantiate. So whenever there is a kidney involvement, or whenever there is an adrenal gland involvement, or whenever there is a testicular involvement or a sinus involvement in the lymph node, or if there is an epidural involvement, as Ranjith said, the sinus involvement is usually going to be in favor of metastatic lesions. Like that, if there is a sinus involvement or if there is an epidural involvement, so definitely there is a risk of CNS involvement as well. We'll come back to IPA in some time. So that is called as International Prognostic Index. So